Zenya, it's okay? So wait.
Or maybe if you sit here, I'll sit there.
Okay.
Because then, otherwise it would be bizarre for me to be.
Zenya, can you start? Nepe. Since you are I'm glad to have with us Professor John Kirkwood, one of the pioneers in the field of metastatic melanoma, lively from Santorini, where European School of Surgical Oncology workshop has been done. Professor Kirkwood, during your whole life, have you ever been in such a good opposition to the exciting years of melanoma?
I think it is a marvelous time to be a medical, surgical, radiation, or other oncologist dealing with melanoma. The first 35 years I worked on melanoma, we had 2 agents that had any impact upon the disease. In fact, one of them was chemotherapy, for which we doubted any real impact. The second was interleukin-2, approved in 1998, which is a very toxic regimen for which we know that the benefits are of small fraction with durability that is perhaps the only unique feature of that. The advent in 2011 of approval for 2 new agents that would have an impact, and this year of 2 new agents, and soon for a combination of molecularly targeted agents, is, I think, a signal for the field that is really exploding, is enlarging in a way that we could never have imagined. I think the challenge for us as medical oncologists for the next decade will be to understand how to apply the different agents we have. On the left hand, the molecular inhibitors of tumor cell pathways. On the right hand, the immunotherapies, which have been with us in the adjuvant treatment and in the advanced treatment with interleukin-2, where the most promising data in checkpoint inhibitor abrogation with anti-PD-1, with anti-PD-L1, subsequently perhaps with other checkpoints that we can block to overcome tolerance, to overcome the immune inhibition, which we know the tumor causes in the patient with melanoma.
Is there still a role for chemotherapy?
So this is a very unanswered question at the present time. I think chemotherapy for patients who do not have BRAF mutations in their tumor were the only non-immune approach that we had any hopes for. I think that we will understand the basis of resistance to chemotherapy in the future, and with that, I think we will learn how to apply chemotherapy in a smart manner, and I think this is really the next challenge.
Do you foresee any future for the combination of anti-PD-1 and anti-PD-L1?
That's also a very interesting question, and I think there are myriad options for combining the anti-PD-1 and the anti-PD-L1. I think perhaps because the interferons induce PD-L1, one of the most rational combinations is the combination of interferon alpha and anti-PD-1. So many rational combinations.
Sometimes when I use ipilimumab, I'm in a very uncomfortable situation to estimate, to evaluate the response. What is your manner to do this?
So with ipilimumab, what you have referred to is the development of immune response qualified criteria. And I think for ipilimumab, this is a problem for the field. I think a bigger problem for the field is that for ipilimumab, the benefit at 2 years is perhaps just 10%. The response rate is just 10%. I think with PD-1, we will get over this because the response rate may be 30 or 40%. The toxicity may be less. I think the reward may be greater. The toll may be less.
Are there any other new molecules, new multi-targeted kinases which could be on the field for the next years?
Yeah, I think the new checkpoint targets, TIM3, BATA, LAG, are all on the horizon for the next several years. And I think these may, because of the data we have from in vitro studies, these may improve the efficacy of PD-1 or of ipilimumab or of the combination, which we already know is promising for PD-1 and anti-CTLA-4.
Thanks a lot on behalf of Greek Medical Society.
My pleasure. Thank you.
Lively from Santorini and from European Surgical School of Oncology advanced course. We have the pleasure to talk with Professor Balch from Texas. And my first question, Professor Balch, is what do you see as personalized treatment in metastatic melanoma?
Well, we don't have the biomarkers that are available in lung cancer and breast cancer. We do have biomarkers for BRAF mutation that helps us select treatment in patients with advanced melanoma. But in patients who have earlier disease, we have developed a website called melanomaprognosis.org. It's publicly available, and the doctors can put in the characteristics of the patient and the histology of their melanoma, and it will give the calculated survival rate at 5 and 10 years. That is very accurate. The converse of 10-year survival rate is the risk of a patient dying of metastatic melanoma in the next 10 years. So I use this very commonly to adjust the treatment. If the outcome is favorable based upon the early histology, we can do more conservative treatment. On the other hand, if the risk of dying of metastatic melanoma is higher, then we want to have more aggressive surgical treatment, and that's where we would add adjuvant therapy, which is limited today, but there are so many new agents coming along that within a few years we will have many different agents to select from, especially for stage 3 melanoma, that we'll have to calibrate or adjust according to the risk of dying of metastatic melanoma.
Do you foresee any future for combination treatments?
Oh, of course. You know, right now there's a revolution going on in the medical management of metastatic melanoma in stage 4 with single agents. And it's actually remarkable that a single agent, some of which are pure immunotherapy, get a high response rate, almost 50%. And among patients who respond, that more than 80% are still stable or regressing 1 to 2 or 3 years later. That's with single agents. They all have different mechanisms of action. So anti-PD-1 is different than anti-PD-L1, is different than ipilimumab. There's some new oncolytic therapies that are coming along, again, with different mechanisms, and then the treatments of BRAF mutant melanoma. So if you look at the strategies used in breast cancer and lung cancer that are targeted therapy, that combinations of therapy will be better than single agents, especially if they have different mechanisms of action. So I'm very optimistic that the world of melanoma management for advanced disease will rapidly catch up with the progress that's already been made in lung cancer, breast cancer, and colon cancer, as we have new agents available that will start out first in stage 4 melanoma, but are already being evaluated in clinical trials as adjuvant therapy in stage 3 melanoma and high-risk stage 2 melanoma.
But for the time being, only a minority of patients are benefiting from the current treatments.
That's correct.
Do you see that in the near future we will have predictive biomarkers, not to spend such a big amount of money and have the maximum benefit for the patients?
Yes. In the near future, the only biomarkers are the BRAF V600 mutation that can be assessed with commercial tests for metastatic melanoma, and for which targeted therapy with the BRAF inhibitors and the MEK inhibitors should be used in combination with those patients, especially if they have advanced disease and are starting to decrease their performance status. Personally, I think even in a patient that is BRAF mutant positive with metastatic disease, if they have limited disease, that the first treatment strategy should be either surgical excision if it's limited disease, or ipilimumab in those patients, and hold the BRAF inhibitors till later, because the BRAF inhibitors and the MEK inhibitors give a dramatic response, but it's not durable. And so if I were sequencing therapy, I would hold that unless we need a more immediate response in a patient who's having organ dysfunction, such as in the liver, because of extensive disease.
We see that medical management of melanoma is continuously improving. Do you see that the same happens also for the surgical management?
Yes, if you look at the strategies in, say, breast cancer, that we have been able to do less surgery safely because of the combination of medical management with targeted therapy, hormone therapy, and even radiation therapy. Right now, because there are so few systemic agents that improve survival rates and reduce the risk of local regional recurrences, surgery is still the primary treatment. But if one looks in the future, in the next 12 to 36 months, there's going to be a very great change as we work closer with medical oncology to, for example, do more neoadjuvant therapy. So I think a model in the future is going to be giving systemic treatment first for a period of 2 months to 4 months, taking the tumor out and evaluating the response based upon how much is inflammatory response, how much is residual neoplastic disease, and looking at the biomarkers within the tumor, and if they've changed, to adjust to a new strategy after surgery. So this model, which is already being used very successfully in breast cancer, I think will be a model that we will be adapting in melanoma in the near future.
Really is an exciting period we are living for melanoma treatment.
Yeah, we have new tools.
New tools.
And the hottest drug coming along is the anti-PD-1 and anti-PD-L1, which have remarkable response rates even with early phase 1, phase 2 studies as single agents. So I think the future is very bright for melanoma patients, especially those with advanced disease for which we've had very few options in the past, to a time where we really will get into personalized therapy for all stages of melanoma. And of course, the